Dr. Sudhank Bharti has made my job a little easier by going through the basics of what Intacs is. I have no financial interest in this product, and I'll just start off with a giant wheel of keratoconus treatment today, which starts off with the most common one would be a contact lenses. Even in a busy practice of keratoconus, at least 80% of our patients are very happy with the contact lenses. The ones who are not happy with the lenses need some form of the treatment. Treatment could be just to halt the progression, or by cross-linking, or combination treatment using cross-linking and ICLs or in Intacs, or if the patients are really bad, then they probably require a keratoplasty. This is the follow-up of a patient, what we do in a clinic, the one which need immediate treatment, which happens only in probably 10% of the cases what we see. Young patients with allergy, thickness very low, documented progression for at least a year, strong family history, and patient with severe allergy and progression. The ones we wait more than 25 years, happy with the lenses, and there's no documented progression, because patients happy with the lenses is what makes a big huge difference in trying to make the decision for keratoconus. This has been described. It just shortens your arc length. That means by the cornea is curved, by putting placement of rings inside the cornea, you're trying to just flatten the center of the cornea, the cone. That's the basic principles of this. How you put the ring is based on the corneal curvature, the cone, and all the many factors. For example, if this is your central cone here, and the placement of the rings on the sides make it tries to stretch the cornea. Basically, Intacs in that way is a very simple procedure. All you need to do is create a tunnel in the cornea. Once the tunnel is made in the cornea, just place the rings just flatten the center or wherever the cone is. A lot of indications, but still the indication keeps changing. One is patient not happy with the contact lenses. The keratoconus itself is very irregular. There's outright failure to use of lenses, and still that the patient is very apprehensive of transplant and he needs some kind of a treatment which is better. Again, when and well, we use Intacs. Again, progressive keratoconus, but this has to be combined with the cross-linking. When you're trying to achieve a better refractive outcomes, when the keratoconus itself is very decentered, when you're not seeing the cone of the cone is not in the center, and you feel the contact lens don't fit, and definitely in an advanced keratoconus. This is a kind of nomogram what we follow in our hospital. This we divide the keratoconus into centered, decentered. It looks a little scary because there are too many things here, but I'm just going to touch upon very basic ones. How do we define what is a centered keratoconus and what is not a center? The center keratoconus is one when you have a cone which is in the center of a 3 millimeter circle. Any topography machine will have a 3, 5, 7 millimeter, and if your cone is at least in the 50% in the center, that's a center keratoconus, and when it's away from it, it's a decentered keratoconus. Now coming to the nomogram, it's here you can see that in a centered keratoconus, if it's stable, this is what we do. We don't do anything. Blue ones are the ones which are very stable. They don't require any treatment. The red ones are the one which shows a progression. Most of our Intacs are in the patient where there is a progressive, but it's a centered keratoconus, or it's a decentered, but its patient wants a better quality of vision. The two main indications to simplify here is in a centered cones or in a decentered cone which shows progression, or the patient is not happy with his contact lenses. This has been described. Symmetrical cone, that means it's a center cone. There are different types of thickness of the rings you can get. Thickness of the rings can start with 0.25 to go up to 0.45. For severe keratoconus, there are different types of rings. So when you see a very central cone, then you put a ring size of both of the same size. That means you can put a 0.45 or a 0.40 because it's a central cone. But when you see a decentered cone, that means the cone is not in the center, then you have to put a thicker ring in the area of the cone and the thicker ring on the top. For example, this is a keratoconus picture. When you see a keratoconus and half of the cornea is actually flat, the blue represents flat, and this is the area of the cornea which needs stability. So what we do in this case is we try to put a ring inferiorly, and always the incision of placement is always as the steep axis. And steep axis, you can get it here. The steep axis is around 154 degrees, so you make an incision here at 154 degree, and the ring is placed. The things to be remembered here are at least at the incision, this is placed at 75% depth of the cornea. That means you take this whole area here and you calculate the 75% of 496. If 75% of 496, if you get a value, say around 350, 375, your depth placement here is around 350 microns. Basically, what we're trying to see is at least place the rings between 350 to 375 microns. The maximum I have gone is around 400, 420 microns. If you go very superficial or very deep, that's where you have a problem. The best ideal placement of it is between 350 to 420 microns. Again, the same thing, the cone is placed here, the rings are placed here, and this is what it stabilizes the cone. You're placing a single ring. In these cases, you don't need to place one more ring here because this place is already flat. You can just place one ring and just you can get very good results. And I'll just show you this video. There are two types of procedures done. One is with the manual, the other one is with the femtosecond. The video? Yeah. And this is by using suction ring, you are trying to create a vacuum. And by putting a vacuum, you are placing the tunnels, and after the tunnels are made, you just have to place a ring. As I said, it's a very simple procedure. All we need to do is create tunnels. How you create tunnels can be done with the femtosecond or you can done with the manual. And here, because this area is flat, we are putting only one single ring. And you can see the placement is around 350 microns, and this is a femtosecond laser, intralace here, and we just have to program it, and this makes the tunnel. And after the tunnel is made, the second stage is just placing the ring. And you just place the ring inside, and you can see the post-op change from this to this. You can see the flattening happening here, and not much of a change here because you have not put any ring out there. Same thing here, a single ring here, and a single ring on top. This is a case where the cone is more central, so we need to place two rings here. And this is the change from the pre and the post and the difference map out here. And this is again with the different machines, FS200, how it's making the cut. And when we do a ACOCT on the table, we see that this is how the tunnels are made, exactly at the depth what you want. What we need to see on the day one, whether it's at least 50% depth, you can confirm it with the slit lamp, whether the sutures are good enough, they're not touching each other, and they're equidistant from each other. This is an incision. The rings has to be away from the incision, and they don't need to touch at the base. And this is why we need an Intacs. You can see here, this is a refraction of the patient. By placing the ring, you change the curvature. The complete changes happen. This is a post-op 3 weeks, but it keeps changing. That's what is very important. You don't get instantaneous results. It changes, and over time again it changes, and after that, this is the difference map, a complete flattening in the center. If you use your nomogram well, you can get excellent results with this procedure. The results can also be improvised or made better by using a combination treatment, by using an Intacs alone. What happens if you use the Intacs alone? I started using Intacs close to 4.5 to 5 years back. This used to be the problem. You get excellent results on the 1 week, and then there is a rebound effect. The cornea has got a memory. What happens is the results are excellent, 10 diopters, 8 diopters flattening, but they rebound back. When it rebounds back, it's after a year, very close to what you started with. But when we start with Intacs, with cross-linking, now we do it simultaneously, what we see is, it tries to hold on. The rebound effect is not as strong as it used to be, but it's still there. There's some amount of rebound effect. What you have on the day one or a 1 week, you will not have at the end of 1 year. Sometimes what happens is there's too much of excessive flattening. You can see from here that there's excessive flattening. This induces more of an hyperopic shift. This is what happens when you try to combine both the procedures, Intacs and cross-linking. So now we are trying to question ourselves, are we doing the right thing in doing it on a simultaneously? Because what happens is there's some amount of rebound. Because when there is too much of flattening, you don't want too much of flattening, because when you're too much of flattening, you induce more of an hyperopic shift, and the patients are just not happy. And especially in a decentered cone, when you have a flattening in one area, you will have too much of flattening in that area. So we are trying to see at what point of time the rebound stops. Probably in most of the keratoconus cornea, again this depends heavily on biomechanics of the cornea. At some point of time the rebound is not it just stops somewhere at this age. Probably is this the right time to do the cross-linking at 1 month? That is something which we don't know, which we need to work on. What we also try to do now is we shorten the time of cross-linking by using a system called Evidro, where our time of cross-linking, instead of making it 1 hour, we try to use it within 3 minutes. So this is more of an accelerated cross-linking where you can change the parameters here and you can adjust the energy. What we use, the normal energy, what we use is around 3 milliwatts per centimeter square. But what we're trying to use is around 30 milliwatts per centimeter square, because it gives you the same energy, 5 joules per centimeter square on the cornea, whether you use 3 or 30. So that's something which we've done. And this is what happens when you do a cross-linking and Intacs together. You can see from here is that this area band here is a cross-linking effect around the Intacs. So this is kind of an additive effect when you're doing both the procedures together. Some word of caution when you're combining both. When we remove the epithelium on the rings, and you get most of the patient used to come with infiltrates for whatever reason, whether there is an interaction of UV light with PMMA or epithelium, which we don't know. So now what we do in the last 2 years, we have stopped removing the epithelium around the Intacs rings. So that is something which and this actually causes thinning and creates more problem. This is just to show that Intacs and cross-linking done gets you a better result. This was presented at the RO and ACRS last year. Get a better result than doing it alone as a single treatment. Just to show how the cone changes by placing the rings in a different place. It can also be used for post-LASIK ectasia, but what we have done is we use it on a femtosecond laser. You can see that flattening here and a good placement of ring. This can be done using, but in this case the only thing which we need to know is right placement of the ring at the right depth. And this is some example how the changes of ectasia has happened over time, and they've been quite stable. And this again to see that we have to wait for close to 180 to close to a year for the cross-corneal effect to take place. It is not an instantaneous result. It does not give you that quick results. You have to use lubrications and any eye shields for at least I use it for at least 2 weeks. And this is something very exciting what we have started doing. We started using a machine called as Corvus, which looks at the biomechanical strength. This you can see this is just shine plug imaging, which looks at this is an abnormal cornea. It tells us how much of deformation happens when you use a jet of air. And you can see that on this side is the. Can you play this video, please? Excuse me. Can you play this video? And this side is the one with an Intacs here, and same patient, the deformation is much less than this when you play this. What happens is this, just to show that the biomechanical parameters also does change. You can see the amount of deformation, amount of indentation of the cornea, and how much of tremors it shows when you use a jet of air. So we've been working on this, and we've been getting good results with when you combine these two procedures. And there was a time when one of our fellows, what they did was instead of putting the ring on here, they put the ring here. So what happens when you interchange the ring, or this just what happens when you have a nomogram which is not right? What happens is you'll have one area which is too flat, the other area too steep. So what does this induce? Unwanted refractive complication. This is exactly what happens when you have the nomogram which is not followed properly. That's one of the big problems with Intacs is the nomogram is the most important thing. If you don't follow it properly, you'll end up in a different segment. You'll end up in an area which is more flat than what you want, and this creates a whole imbalance in the cornea, and this actually causes more problem. So all you need to do is remove the ring like what we are shown here, and adjust the rings accordingly to your needs. We just started this for a very irregular cornea. Initially, all our patients were waiting for lamellar keratoplasty. What we did was, in a cornea which is very irregular, we just started off with giving a little bit of laser that we call cross-linking and topo-guided PRK, like what Dr. Bharti said. We started doing it without actually entering the refractive error. We just started this with only trying to make the cornea more regular. And after that, Once we started stabilizing this, then we started putting rings. So we call it C3R. I mean, you would think that there are too many procedures happening. For me, at this point of time, this is one after 4 or 5 patients who are finishing close to a year. They're one which got very good results. At least we have stopped the keratoplasty for some time. The problems of Intact definitely is unpredictable. There has to be a proper nomogram. Biomechanical factors and regression are the major factors. It's also issues of cost, learning curve, and the contact lens fit after Intacs is one big issue, which again is, we know they're not happy with the RGP lenses like what many places have shown. Piggyback lenses or one of the Boston scleral lenses are what we need to do. I'll just take a minute and I'll finish it. Some issues like tight suturing, this is what you get with the scarring. Sometimes the wound opens up, there is some amount of gaping, there's some amount of epithelial plug, but they're insignificant, they don't really cause much problem. Even rings touching each other, we have to be very careful about not to push the rings too much so that they touch and create an issue. But if you are deep enough in your cornea, then there is not an issue. But if you are very superficial, the issue of extrusion or thinning is always a problem. When you look at grade 1, there is a smile loss of transparency here, but still okay. But there are issues like this, where there is a lot of deposits. These deposits are nothing but dead keratocytes, lipids, not really sure, but there's one paper which I've done, a histopatch showed that is more of a keratocytes issue there. But one of the issue what we have seen is when there is a vascularization at the wound site, you can see here, that's when you start more of deposits, and this vascularization many times happens during patients who are not fitted with good contact lenses. So we try to somehow use anti-inflammatories or steroid for some time to see that we don't have a vascularization at this site. These are the deposits on an anterior segment OCT. And this is just a paper, one of a paper which showed that deeper you go in the right placement, you get better results. And if you're very superficial, most of them sometimes end with melting or a corneal thinning at this point. And sometimes a very poor, sometimes very long-standing thinning can also cause microbial keratitis. And this patient, we had to remove the ring from his eye. The future is going to be probably, you'll hear a lot about this in this conference, is about the new microwave pulse treatment, which gives more or less the same kind of a treatment effect like this, but without implanting ring. Whether how much it's going to make a difference, we don't know. With all this, we need to know that there are multiple level of tear markers in the cornea which may play an important role in the progression of keratoconus, especially matrix metalloproteinase 2 and 9. So most of the things are not known. So this, if you understand all this, probably our outcomes will be much better. Thank you.